Well, we have a good turnout. Thanks for coming. And it's my pleasure to introduce Dr. Christopher Booth, who truly is an amazing person and physician. So I actually met him through a connection on social media. I know I take a lot of flack for social media, but it brought this person into my life and his family. So there's very few people on this planet that have changed the way I think about things and how I approach things. And his work and from talking with him have actually largely impacted how I view the whole oncology field and the literature, and it's changed the way I think and practice. And so I'm very gracious that you guys have come to kind of hear what we've been working on, which is called the Common Sense Oncology Movement, largely based all on Dr. Christopher Booth's research. And he came all the way from Kingston, Canada. If you don't know where that is, it's a college town on Lake Ontario, and you have to take a 2 to 3 hour train or drive to Toronto or Montreal, then to fly all the way here. So he's here, and we're going to take him for some good tacos while he's in town, because they don't have much in Canada. But it's my pleasure to introduce him, and he can take it away.
Thanks, Aaron. Thank you. Very grateful for everyone being here today, and for Aaron and his family hosting the Booth family in San Diego. We've enjoyed our time here so far. So I'm going to talk about this initiative we've launched called Common Sense Oncology. And this is a movement that I think resonates with all of us that look after patients with cancer and who do research in this space. And it's been incredibly well received over the last couple of weeks since we launched the movement formally. And I think it's because everyone inherently knows that there's many things we do well in our field, but there's some areas that we can do better to improve things for patients. So I want to spend some time going over that today. I have no relationships with the pharmaceutical industry. In fact, if the trainees are interested, they can read a story about when I was a fellow. I went to a pharma dinner, and I actually had an $80 hamburger, and it was a pretty good hamburger. But anyhow, that led to this kind of long journey, which we wrote about in an essay in the British Medical Journal a few years ago. But in any case, the disclosures I want to make actually up front are, I've been giving talks like this now for many, many years, and which are often very self-critical of our field. And I always worry that we come across as uncaring when we talk about these issues. But I just want to emphasize and start that this whole movement is grounded in a very deep sense of caring and compassion for the patients that we have the privilege of looking after. And the entire reason I went into oncology was because of these privileged doctor-patient relationships we have when patients and families are in a very vulnerable state. And we're very, very lucky to be able to guide them through that journey. And I think the essence or the art of oncology is delivering compassionate care and communication. Sometimes we also deliver treatments, but really it's compassionate care that is the core of what we do. And so what that tells me is that if we're going to give treatments, it should be treatments that really help people. And we need to be honest and talk about that. And some of our treatments truly are transformational and have large benefits for patients. But there's also quite a few things that we do that have very small benefits. And when you think about the downsides and risks and toxicities for patients, some of them I think we need to question and ask ourselves, are we really helping? And so that really, I just wanted to set the stage with those comments. But first, I just want to acknowledge my host. So Aaron has become a very good friend over the last couple of years. This is, Aaron's been to Canada twice, and that's why he wears a lot of toques. The first picture, he's known as Forrest Gump in Canada because he runs for like hours every day. And like everyone in Canada sees, who's this guy? It's warm outside. He's wearing dress pants, a sweater, and a toque. And it's this kind of like, is he a mad scientist who escaped from a rock and roll band? Who is this guy? But it's been a wonderful privilege to work with Aaron, who has been one of the inspirations behind actually launching this movement. We've been working on this academically for 15 or 20 years now, but it was Aaron and Bishal Gawali who kind of nudged a few of us to say, we need to make this a big movement and embrace the community and do this together. And so I'm very grateful for the friendship and the leadership that Aaron has shown in this space along the way. Now, some of the fellows were asking me, do you have any tips when I work with the famous Dr. Goodman? And they said, sometimes we say things in clinic and his hair gets bigger and he starts talking faster and faster, and it clearly upsets Aaron. And sometimes, we say things that really make him happy. So I want to go over some things, and you can choose. There's a couple things in here that I would suggest you say in clinic and other things you might not want to say. Okay, you should avoid making any of these comments except two of them. Which ones? I'll let the fellows kind of guess which ones. Nirvana and Bach are overrated. So Aaron might get slightly agitated if one of the fellows were to say that. Dose-adjusted EPOCH-R is still the bee's knees for all aggressive lymphoma. I'm a colon cancer doctor, and Aaron convinced me that probably is a false statement. Poutine from Canada is better than his famous tacos in San Diego. That'll really get Aaron going, although he does like poutine. The internal medicine MOC makes me a better doctor. I'll leave that conversation for another day. And this is actually a true statement. Aaron Goodman is known as the Forrest Gump of oncology. He would disappear for like 2 hours. And I'd be like, Aaron, I'll pick you up at the library, the hospital. He's like, oh no, I'll just run over to your house. And it's like 15 kilometers. And then this is the real Aaron Goodman, that the most important job of oncologists is to deliver compassionate care with clear communication. Aaron's been very clear, and that's, I think, why he's so well regarded as a clinician and as a teacher, because this is what drives him, and his heart is at the center of everything he does. So we're going to spend the next 30 or 40 minutes going over a few things. I'm going to start with 3 paradoxes of cancer care. Then we're going to veer into what I call the cancer value crisis. A few comments on global cancer care, because this movement is truly global in nature. And then we're going to talk about this movement we've created that we want all of you to join and become engaged in, the movement in common sense oncology. But to set the stage, I think often we do a lot of good in our field, but some of the challenges in our field, I think, happen when we forget really the core mandate of what matters. And so what do we as oncologists, other clinicians that look after patients with cancer, investigators and staff, what do we really care about? I think we care about access to care, equity, health justice, affordability, quality of care and outcomes, and patient-centeredness. And I think if we keep these domains at the center of everything we do, we'll be on the right path. And so I think I just wanted to set that at the beginning of the lecture. So the cancer medicine paradox, this is paradox number 1. We have substantial overutilization of marginal, toxic, and expensive medicines, especially near the end of life. While at the same time, due to problems with access and affordability, most patients in the world, in US and Canada, there are also pockets of patients who are also vulnerable in this context, but outside of North America, many patients don't get access to those cancer medicines we have, which truly are transformational. So this is paradox number 1. Paradox number 2 is that we've had an explosion in what we know about cancer. And so we can deep sequence tumors. We know more about cancer biology. You guys do. Aaron and I don't really understand that, but people can deep sequence these tumors. And at the same time, we know so much about the biology, yet we fail at fundamental elements of care like communication. So this is a famous paper by Jane Weeks and colleagues years ago, replicated recently, showing that many patients with cancer don't even know if their cancer is curable or incurable. And they think the treatment they're getting is going to cure them when the reality is their life expectancy is 6 to 12 months. So we have this paradox. We have more knowledge than ever, but at the same time, we're not sharing some of the fundamental elements of our field. And then the third paradox, I call this the last 6 months of life paradox. And so this is fairly easy for me as a clinician when I'm seeing someone in the refractory metastatic setting. They've gone through standard treatments, and we have access to a medicine that probably costs about $100,000. We know that there's no clinical trial data saying it's going to help someone live longer or feel better. It might delay tumor growth on a CAT scan by a few weeks or months, but it certainly is going to have side effects for the patient. And it's also going to consume some of their time at a moment when time is most precious near the end of life. So we have a health system in Canada and the US that will generally allow us to prescribe something like that, which really has very limited utility. But at the same time, it's almost impossible to find the right psychosocial, nutritional, and nursing supports to help that patient at home spend the remaining months and weeks that they have to live with comfort and dignity. So we have this real paradox. And I am inspired by the next generation of oncologists because there's remarkable talent and energy out there. And so one of the reasons we launched this movement was to inspire the trainees and the next generation of leaders in our field to tackle these really fundamental issues and not to dedicate their career to chasing some marginal gains that our generation perhaps has set out to do. So cancer value crisis. This is driven by at least 5 domains. We have some problems with clinical trials. We have dubious endpoints. Some of our therapies have very small effect sizes. We have a very staggering price of new cancer medicines. And fundamentally, we have a communication breakdown both at the bedside between doctor and patient, but also more broadly with the public, with the media, with regulators and payers. So let's unpack that. This is a piece we wrote years ago about some of the challenges with randomized controlled trials. I'm not going to delve into this, but I do want to say that while there are some problems with randomized controlled trials, I just want to be clear that this remains the gold standard and the best way to identify new therapeutic advances in our field. There's a huge movement right now towards abandoning RCTs and using real-world data. And as someone who worked intensively as a health services researcher with real world data, I want to be very clear. I'm not advocating, and our movement is not advocating for a shift away from trials. If anything, we actually want renewed interest in clinical trials, but we need to use that tool wisely and design trials that matter to patients. Value. So I'm not a health economist. I think upon this issue as, a simple oncologist from Canada. There's two relationships here. We're looking at the numerator, the magnitude of benefit. How much does this treatment help my patient? And the denominator, which is the cost. And a lot in our field in the last decade has been written and spoken about the denominator, the cost. And I believe that we should continue to speak out about outrageous and unjustified costs of cancer medicines and other elements of care. But I think we also need to pay attention to the numerator, because as individual oncologists, we have very little control over the denominator, but actually we own the numerator. We're the ones that design trials, write guidelines, make recommendations at the bedside with our patients. And we need to think about how can we shape the numerator to ensure that our patients get access to treatment that really matters. So when I see a new clinical trial or I'm teaching a trainee about a new advance in clinic, I say there's three questions. Number one, what was the endpoint that was shown to be better in the relevant trial? Number two, how much better was the new treatment? What was the effect size? And question three, do both of these things matter to patients? And if they don't, we should probably forget about that treatment. So you'll see most of my talk is going to focus on the numerator, but let's just talk briefly about the costs of cancer medicines. So this slide's a little bit older now from Vinay Prasad's group, but you can see the staggering rise of cancer medicine cost. And this is now, 5 or 6 years out of date. We now live in an era where the typical new cancer medicine costs $200,000 per year. I think it's important to acknowledge that. And if these were curative intent treatments or treatments that help people live for extra years, that's one conversation. But as we'll see later, the majority of these cancer medicines just shrink tumors on a CAT scan for a few months. And so I think we need to have some honest conversations about where we're going when it comes to cancer medicine pricing. The next construct, this is a paper we published a few years ago in LANCET Oncology, where we asked a very pragmatic question. So this is a question all of us in the rest of our lives outside the cancer center ask every day. If Aaron wants to have a nicer taco, he spends more money, he gets a bigger, nicer taco. If someone wants to have a faster bicycle, they spend more money, they get a faster bicycle. And we asked, does that relationship apply to cancer medicines? And we found that not only is there no association between the magnitude of benefit and drug price, if anything, we found the inverse, whereby the drugs with the smallest benefit had the largest price tag. Now, you don't need to have a PhD in economics to note that's a very broken pricing system that needs to be addressed. And the last comment I want to make about the denominator of value, which is kind of the financial side of cancer care and cancer medicine, is this massive shift in the biomedical industry. And so this was a paper we published last year in Cancer, where you're probably not allowed to do this in the US, but in Canada, we're still allowed to torture medical students and residents with tedious research projects. And so we had a team of students and residents who read financial reporting documents for every major pharma company, 10 of them, for 10 years. That was like thousands and thousands of pieces of paper. And we didn't care about any of it except for one simple question. In each given year, for each specific company, if you look at their sales revenue for medicines, what proportion was for cancer medicines versus non-cancer medicines? And you can see the orange curve on top shows that over a decade, the sales revenue for these 10 largest pharma companies went up by 70% for cancer medicines, and their revenues for all other diseases and medicines went down by 18%. So the entire industry has pivoted and shifted into cancer. And, on the surface, this might seem like a good news story for oncology, but I think there's alarm bells here for two reasons. Number one, I think all of us would agree there's a lot of other really important public health and disease processes where we need important advances in therapeutics. So it's not all about cancer. But the other warning sign is that there's not many elements in life where more and more and more and more money is a good thing. And so where we're at now is there's so much money in the system that it's led, I think, to some of the problems that we're going to unpack over the next few minutes. So this is a very famous slide that I borrowed from one of my formative mentors and teachers who continue to work very closely with, Professor Ian Tannock from Princess Margaret Hospital in Toronto, where I trained. And so Dr. Tannock would drill into our heads as trainees, and I think this applies to every area of medicine, not just oncology. There's only two goals of what we do in medicine. We want to help people live longer lives, and we want to help them feel better and have a better quality of life. And so accordingly, the only two important endpoints of a phase 3 trial really are overall survival and quality of life. Everything else is a surrogate, and often these things are not valid surrogates for what really matters. And so Dr. Tannock pushes this, and I'm going to show this slide. The good thing about being from Canada is I can say anything outrageous and people don't take us all that seriously, so I can get away with it. So this is an outrageous slide. Aaron likes this one. What should we call an agent that increases progression-free survival, has no effect on survival, and adds toxicity? First of all, that describes many trials we read every week in JCO. It describes many oral presentations at our national meeting. And Dr. Tannock would provocatively argue, we actually should not call these game changers or breakthroughs or huge advances for patients. We should probably call them for what they are. These are harmful. These probably cause a lot more harm than we often are willing to acknowledge. I gave this talk virtually in Australia last week, and right before I hit the button for harmful to come on, the internet went down. And I was like, someone's watching this. And by the time I got back on Zoom, the Australians were debating, well, what did he say? What's he going to say? And I was like, the punchline here is harmful. In any case, I'm glad it didn't get shut down. Okay, so now we're going to shift to endpoints. Progression-free survival. This is now the king of oncology. When I was a junior whippersnapper, 10 years ago now, another of my formative mentors and teachers, Dr. Elizabeth Eisenhower, at the Canadian Cancer Trials Group at Queen's, where I work now, we noticed there was this new kid on the block, progression-free survival, which Elizabeth had been one of the inventors of as a phase 1 and phase 2 trialist. PFS and response rate and RESIST were invented for early phase trials to measure tumor activity to decide should it move forward into phase 3 testing. We noticed in the late 2000s, it was starting to be used as the primary endpoint of RCTs, which was not its intent when it was created. So we wrote this essay a decade ago, progression-free survival, is it meaningful or simply measurable? And I must admit, 10 years later, it upsets me to think that we're no further ahead. And in fact, I'm going to share some data now that tells us that although we're using PFS all the time, it might not be meaningful or measurable. So just for those of you, I'm just going to nerd out a little bit here. So what does PFS mean? Even most oncologists aren't totally sure of this. So it's a composite of survival, okay, which matters to patients, but then also tumor growth and shrinkage on a CAT scan. So just to break it down, tumor progression, if you have 20% increase in diameter, that considers an event. So you can see here, like these are pretty subtle changes. So imagine a typical patient my size who's got a lung met that's that big. And if it goes to that big, ding, that's a PFS event. But it doesn't take a lot of creative thinking to imagine, well, if it goes from that big to that big, the patient probably doesn't feel any different. And are they really going to live any longer? And so there's a lot of uncertainty about, does progression-free survival, does it actually translate into a difference in overall survival? I'm going to convince you that in most cases it does not. So putting progression-free survival in context. So PFS may be useful if it is a surrogate for something that matters to patients. But we've learned now that there are some circumstances where PFS is a valid surrogate for overall survival, but in most contexts, that's not the case. We've also learned that actually it's not the case for quality of life. We have ways to measure how someone feels, just use the quality of life instruments that we have. Progression-free survival may be useful if in itself it has intrinsic meaning to patients, but this is far from certain. We just published a paper last week in JNCI where we actually interviewed patients. I'll share that data in a moment. But when we consider the trade-offs for patients with their side effects and their time, it's unclear whether tumor measurements alone actually matter to patients. And finally, even if point number 1 or point number 2 are correct, there's increasing data that we might not even be able to believe a measurement of progression-free survival due to artifact. I'll touch on that in a moment. So why is it that PFS may not predict overall survival? Well, it might be that the amount of tumor growth is so minimal that it's not going to help someone live longer or feel better. As I said, going from an inch to an inch and a half. Or it might be the amount of time of growth, right? So why is it, I used to tease my trainees, if I said, what was the result of that clinical trial? And they didn't know, I would just say, you don't need to read the trial. The benefit's always 6 weeks of PFS. And that was a joke. It's not always that, but it often is. And why is that? Because the CAT scans were done every 6 weeks. So we're looking at small amounts of growth over a different of maybe 6 weeks or 2 months. So maybe that's why it doesn't translate to improvement overall survival. And finally, being alive or dead is a pretty objective, solid thing to measure. But tumor measurements are prone to bias, both through measurement error, but also something called informative censoring, where we might not even be able to believe the result that we get. So we've done a deep dive of this, going to patients and asking them what they think about a cancer treatment that doesn't help them live longer or better, yet might control tumor growth in a CAT scan. So we did a systematic review published in NGS and Oncology a few years ago. And then we've just published this paper listed below in JNCI. I just want to walk through that. So this was a study of 100 patients with lived experience on palliative chemotherapy. They all had incurable solid tumors. And they went into an interview where they were given a hypothetical treatment option. And we told them, imagine that the current treatment you're on is no longer working. Here's a hypothetical treatment. Here's a list of the side effects, pretty standard side effects. You're going to be in clinic 1 day every couple of weeks for treatment. Unfortunately, this treatment will not help you live any longer. What it might do is control the amount of time on a CAT scan before the tumor grows. And we wanted to see how much added time on CAT scans would a patient want to warrant the treatment? Did they want like 2 years or 3 or what? So we started at 24 months. Would you do it if it controlled tumors for 24 months, and then 22 months, then 20 months, then 18? And we marched down to see where they would flip and say, no, I'm not interested in that treatment. And it became very clear, first of all, more than half of people just stopped the interview and said, under no circumstances would I want that treatment. About a quarter of patients said, I would do it, but I want a PFS gain of 3, 6, 9 months. Okay, not 6 weeks, not 4 weeks, not 8 weeks. And what's interesting, and here's a communication breakdown, 17% of patients interviewed said they would accept a toxic treatment that doesn't help them live longer and doesn't even shrink tumors on a CAT scan. Okay, so there's some very profound issues in our field there we need to do as far as how we communicate with patients and how we offer treatments that really might be seen as being futile in many contexts. So I think this was an important study because it tells us that for most patients, they want to live longer and better. And if it's just going to control tumors on a CAT scan, they're not all that interested. So what do we know about effect sizes? We've talked about endpoints. Okay, we've seen that PFS is now the dominant endpoint in oncology, but there's some major challenges with it. What about effect sizes? There's a nice paper that came out recently where they looked at all new cancer medicines approved by the FDA. Across 374 new FDA indications for cancer medicines, about 1/3 of these new medicines improve overall survival. Okay, so the vast majority of new medicines that are approved, that are put in guidelines that we read about in newspapers, there's no evidence they help people live longer or feel better. It's driven by PFS. But amongst those medicines that do help people live longer, this is an important number, 3 months. And this has come up over and over again, work from our group and from others. If you look in aggregate of the amount of time that a new medicine helps someone live longer, it's about 3 months. Now, clearly this is aggregate. So there are drugs that are transformative that help people live for extra years of life. But on average, it's about 3 months. Now, I don't want to take away the meaning of 3 months to anyone or their family who's facing a terminal diagnosis. But I think it's important to have humility and recognize what this 3 months involves and what it means. So this is clinical toxicity for our patients. They feel sick. There's financial toxicity for the patients, for the family, and for the health system. There's something time toxicity, which we'll touch on in a moment. And then there's the concept of the efficacy to effectiveness gap. And so we've worked very intensively with real world data over the last 15 years. And what we've seen over and over again is that the results and the benefits of new medicines and treatments in clinical trials are always attenuated in the real world where patients are older, sicker, and have more comorbidity. So if we're looking at improved overall survival of 10 or 12 weeks in a trial, in the real world, it's going to be less than that. Is it 3 weeks? Is it 5 weeks? Is it 7 weeks? And so this needs to be in the back of our mind and also inform conversations we have with patients. So time toxicity, this is something we started writing about a couple of years ago, and this really resonated deeply, I think, with patients and also with clinicians, because all of us, I think, have had that sick feeling in our stomach when we see a patient on a Monday in clinic and we say, how was your week? And they say, oh, it was fine. You know, I decided to skip my cousin's wedding because I didn't want to miss the appointment today for the dose of palliative chemotherapy. And we've all had that experience where you think, oh, you really should have gone. You know, we could easily delay or change treatment here. And so I'll just paraphrase a line from our essay. Time spent pursuing cancer treatment in waiting rooms, emergency rooms, and the chemotherapy unit is time that cannot be spent fishing, traveling, or visiting with loved ones. This trade-off becomes most pressing near the end of life when time is short and many of our treatments offer small benefits. So if someone is being offered a curative intent therapy, or they have an expected lifespan of many decades, the amount of time they invest for cancer care is probably a very reasonable trade-off. But when someone only has 6 or 12 months left to live and the treatment benefits are very small, those added days, spending 1 day a week in the chemo unit, can be an important consideration for them and their family. So this was a follow-up essay led by Arjun Gupta in Minnesota, where we proposed a measure of time toxicity called home days, that we need to, as oncologists, it's not my job to tell or suggest to a patient how they spend their time in the last year of life. But I think we have failed as clinicians because we don't talk about this. We don't allow people to understand what life will look like on treatment. And some of that is because the clinical trials, which collect 1 billion data points on serum rhubarb and all sorts of other stuff, we don't actually count, you know, how many days you're going to spend in the chemo unit, the emergency room. And so we propose this measure, home days, that we think in the context of a palliative treatment should be measured so that a patient can understand, because we've done modeling for some refractory solid tumor settings where any extra day of life will be offset by a day spent in the emergency room or the chemotherapy unit getting care. And so that's an important consideration. Patients want to know about that when they make decisions, especially when time is short. This is a slide just to summarize that concept. We wrote about this in JCO a few years ago. The efficacy to effectiveness gap, over and over again, we've seen that the outcomes and the benefits observed in trials are smaller in the real world. And so I think we need to be mindful of that when we're making treatment recommendations to our patients. Just briefly, I just want to give you some data about where have we come from in our field and where are we going and why do these issues matter? Because the second part of the talk is going to be, well, what can we do about this? And it's time to start talking about it. So this is a series of papers that we started when I was still a trainee at Princess Margaret Hospital. We called The Evolution of the Randomized Trial in Oncology. And we've published 3 iterations of this. So the first paper was published in 2008 when we looked at all clinical trials in the major tumors, breast, lung, colorectal, published over 30 years. And we call that evolution of trials in the era of cytotoxics. We updated it in the early 2000s. We call that the molecular era. And lately, we just published in JAM Oncology last year, what do clinical trials look like in the era of precision oncology? And so this is the one picture that says it all. So you can see the clinical trials in the 70s and 80s, when our teachers were running things, were designed to improve overall survival. That was the dominant endpoint, okay? Oncologists and trialists were trying to help people live longer and cure their disease. But you can see what's happened over time is now the minority of trials are trying to improve overall survival. We live in an era now where half of clinical trials are designed with the intent to slow tumors on a CAT scan. So as I said earlier, progression-free survival is the king of oncology, and this is the picture that shows it. The other thing you can see is the brown curve shows that in the early years, clinical trials were funded largely by government grants to cooperative academic trials group. And as those grants have become harder and harder to get, and our therapies have become more and more expensive, you can see that we now live in an era where more than 90% of oncology RCTs are funded by the pharmaceutical industry. And, you know, I've been very critical of pharma in other contexts, but I do want to make a caveat here and say, I'm not suggesting we have no relationships with pharma. In fact, many of our very effective transformational treatments come from well-done clinical trials done in partnership with the pharmaceutical sector, but the pendulum has swung too far. And when 90% of trials are being funded by a pharma industry, we're unable to answer other questions that really matter to patients about treatment de-escalation, about lifestyle interventions, about reducing toxicity, et cetera. So just a few comments on global cancer care. I had the privilege now many years ago of spending a sabbatical in India where I was a visiting scientist at a large cancer center in South India. And since then, I've worked very closely with colleagues in South Asia, largely in India. And also I have a policy role with the World Health Organization, which has really influenced the way that I see cancer care in the global context. So I just want to make a few comments about that. So this was a paper we published 2 years ago in JAM Oncology, where we looked at all clinical trials in oncology, not just medical oncology. This was looking at surgery, radiotherapy, and drug trials, published over a period of 4 years. We had 700 trials, and we were interested to see, do the trials match where the disease burden is? And so the global cancer crisis is a scenario where 2/3 of global cancer deaths now take place in lower and upper middle income countries, yet we only spend 5% of our global resources in those contexts. So as those countries have undergone a demographic transition, they also are undergoing an epidemiologic transition, where many of these countries are now having explosive changes in their cancer demographics. So you can see here that 90% of oncology trials are led by investigators in high-income countries. We found that if you look at the cancers that cause the greatest public health burden in the world, including lung cancer, cervical cancer, esophageal cancer, liver cancer, and gastric cancer, those are massively underrepresented, okay? So cancers of poverty are underrepresented in the global agenda. Also this stat here, so even as a medical oncologist, I can recognize 87% of oncology trials are testing new drugs. Only 13% are looking at new interventions in surgery and radiotherapy. We like to think that, FOLFOX and, our medicines make a huge difference, and they do. But the reality is most patients in the world who are cured of their cancer, they're cured by surgery and radiotherapy. And so we need to recognize that this investment only in cancer medicines comes at a cost to other elements of cancer care, let alone one of the most important elements, of course, which is palliative care, psychosocial oncology, and prevention. Finally, we saw that clinical trials led by our colleagues in lower middle income countries, they tend to be smaller, they're more pragmatic, and they're designed to detect larger differences. So in fact, we can learn from our colleagues who are publishing trials in lower resource settings who don't have the quote unquote luxury of designing mega trials of expensive therapies to detect trivial differences. And we found that despite the fact that we have much to learn from these powerful trials elsewhere, there's a publication prejudice whereby they're published in much, much lower impact journals. And that's something at the editorial and reviewer level that needs to change. So just the last couple of comments on global oncology before we shift to common sense oncology. A lot of what we work on relates to something called the cancer ground shot. So this was an essay we published in LANCET Oncology a few years ago with my very close friends and colleagues, Bishal Gowali, who's a medical oncologist based in Kingston with me at Queen's, and Richard Sullivan, who's a cancer policy thought leader in the UK. And much has been written, of course, about the cancer moonshot. Cancer moonshot initiatives are high-tech, aspirational, big science interventions that might improve outcomes for some patients in 10 or 20 years. And we need moonshot aspirations, but we also need to look on the ground. Ground shot initiatives are initiatives that will improve care today for the patients. And I would argue we could actually have a bigger public health impact if we ensure that patients today all get access to treatment that we know makes a big difference. So we need to recalibrate the moonshot and ground shot initiative. So along those lines, this is a piece that we led that came out of work we do with the World Health Organization. We call this the Desert Island Project, where we did essentially a survey of 1,000 oncologists in 80 countries worldwide. And we asked them, what medicines are the most important to you in your practice? And are these medicines available? And the reason we called it the Desert Island Project is this was the key question on the survey. I think you've probably all played this, at dinner parties. If you're moving to a desert island and it can only bring 3 books, what would those books be? If you could have a dinner party with any famous person in history other than Aaron Goodman, who would it be? And so the Desert Island project here was, imagine your government has put you in charge of selecting anti-cancer medicines for your country. You're only allowed to select a maximum of 10 medicines that will be available to treat all cancers in your country. Which drugs would you recommend to achieve the greatest benefit for the most patients? Assume that cost is not an issue. So we had about 1,000 respondents. 1/3 of them came from lower resource health systems. And what we found that when we looked at the medicines that were most commonly put in that suitcase to move to the desert island, they were the good old fashioned drugs we've been using for 10, 20, and 30 years that we know have huge benefits. The anthracyclines, the platinums, the tamoxifens. So most of these are old drugs that should be very, very affordable. There were some newer drugs that people wanted to take to the desert island, trastuzumab, imatinib, rituximab, but it was the medicines that are new, and even though they're expensive, they do have large benefits. So the clinicians are pretty pragmatic about what they want to take to that desert island. And you can see here the list, the good old fashioned doxorubicin, cisplatin, paclitaxel. Again, some of the newer drugs are on there, but those drugs that have major benefits. But this is where the system falls apart, because remember, most of these drugs have been around for 30 years. They should be very affordable in every health system. So for example, doxorubicin at the top, only 1/3 of oncologists said they can provide this to all patients in their practice universally. 1/3 said they can do it, but there'll be significant financial expense for the patient. And about 1/4 said, if I give this to my patients, it will cause catastrophic financial ruin for that patient and their offspring. And this is doxorubicin, same thing, trastuzumab, which is now the biosimilar version of Herceptin, now available. Only 15% of oncologists can provide this universally to all women with breast cancer in their practice. And 2/3 said, I can give it to my patients with HER2-positive disease, but it will catastrophically ruin that patient and their family. So this is a big problem and speaks to one of those paradoxes I mentioned at the beginning of my talk. So I now want to close with comments about what we think we can do about this. And so this is an initiative that grew out of, many years of doing work in this space and conversations with people all around the world that I know care about this. And Aaron was really one of the people that pushed us to do this, because as Aaron said, the idea here is to take this out of the academic journals and bring this to the people and recognize that everyone in the cancer system cares about the same things. And we need to start talking about these issues, recognize what we do very well in our field, but be willing to be self-critical, to talk about it and be collaborative toward finding solutions. So Common Sense Oncology, which is an initiative, a grassroots movement, please all of you join. I'll show you the website at the end. And it's all about pursuing a cancer system that delivers outcomes that matter to patients. So some of the constructs came out of a paper that Bishal and I wrote in Nature Medicine about a year ago, which is we need to transform how we deliver care, how we educate oncology clinicians, and how we undertake research and policy. So this had been really just an academic exercise until we decided, let's launch a movement. And so to do that, we actually started with 30 people. These are 30 people from 15 different countries, oncologists, academics, journal editors, and most importantly, 4 patient advocates from different health systems that came to Queen's University in Kingston. You can see Aaron up there in the back eating a taco with his guitar. And for 3 days, we sat in a room and we talked about who are we, what do we care about, what do we want to work on, and how are we going to get there? And it was a very intense 3 days. I mean, we had lots of fun, but especially the first day, there was this raging debate about what we were going to tackle, what was realistic, what was feasible. But out of that, we launched this movement. And so I just want to acknowledge, there was 5 of us that spent a lot of time planning this meeting. Aaron, myself, Bishal from Queens, Brooke Wilson, a medical oncologist from Queens, and Manju Sengar, who's a hematologist and chair of the medical oncology department at the Tata Memorial Hospital in Mumbai. And so, but we had really amazing engagement from these initial 30 people that came to Queens. And then we formally launched last week. So we synthesized our ideas, our vision, and what we wanted to do. And while we started, we had to have a small group for planning purposes, but we wanted this to be a grassroots, very inclusive movement. We welcome participation from clinicians, from patients, from advocates, from researchers, policymakers all over the world. And it's been really quite remarkable, the reception, because I think all of us recognize that there is things that we need to talk about and work on. And it's been very, very well received. So we want to focus on outcomes that matter to patients. The vision is that people, regardless of where they live, have access to high quality cancer treatments that deliver these outcomes. Patient outcomes that matter should be the core of everything we do in research and in clinical practice. We need to do a good job reporting trials so that clinicians, the media, policymakers, and patients understand what they're getting into. We need to do a better job at the bedside, having very clear communication so patients know, is this treatment going to cure my cancer or not? Is it going to help me live longer or not? What are the downsides with my time and with side effects? We need to work with our policymakers to ensure that those treatments that are beneficial to patients are funded and available for people regardless of where they live. But we need to be willing to recognize that those treatments that actually do not help people, we probably shouldn't be putting them in guidelines or recommending them. And we want to focus on, there's an education pillar that Aaron is helping to lead, and health systems also need to ensure this balance of moonshot and ground shot. So how are we going to get there? We have a series of guiding principles. Access to quality cancer care is a basic human right. Cancer research and delivery of care should not be driven by financial interests. It should be driven by patient and societal need. We should involve patients and public when we're making research decisions, we're making policy decisions. Clinicians should recommend treatments that help people live longer and live better. If a treatment doesn't do that, there needs to be a very clear rationale for why it's being proposed, and patients need to be made aware of that. That facilitates true shared decision-making. Cancer treatment should be fairly priced for the context in which they are used. Equity to access for high quality care should be universal. So it shouldn't matter what country in the world you live, you should have access to the care that makes a big difference. And comprehensive patient-centered care is more than just cancer medicines. We need to embrace psychosocial oncology, prevention, palliative care, and the other disciplines within the cancer system. So the 3 pillars of work. So we had to decide what is it that we're actually going to work on and how are we going to get there and what will be the metrics of success. So we have 3 core pillars: evidence generation, evidence interpretation, and evidence communication. So starting upstream of care delivery, we need to look at the clinical trials that will inform future care, use and clearly report outcomes that matter to patients. When it comes to evidence interpretation, this is the education bucket. We want to make sure that clinicians are trained in both critical appraisal, how to dissect a clinical trial and identify a trial that is well designed from one that has flaws, but also train in critical thinking and be willing to think outside the box and not just follow guidelines without considering the values and preferences of the patient in front of you. And then the third bucket is evidence communication. We need to do a better job of communicating what these cancer treatments mean. And that's communication at the doctor-patient level, but also communicating with the public, with the media, with policymakers and payers. So these are the 3 core pillars. And we have a series of project teams that have already been launched a couple months ago that are actively working on this. So there's a project team looking at how we can better design and report clinical trials. The education team, which is being co-led by Aaron, is looking at how we can do a better job educating clinicians and trainees about principles and common sense oncology. There's a broad piece of work with stakeholder engagement, working with the people who fund clinical trials, working with IRBs, working with the cooperative trials groups to try to understand how we can collectively move or recalibrate our system back towards outcomes that matter. The Patient Priorities Project team is working with patients and patient advocacy groups to find out what matters to them. What do they see in the cancer system that's working and what's not working? And how can we realign things to ensure that we're delivering high quality care to patients that matter? And there's a project team looking at the policy and politics of what we're doing in cancer systems. So just wrapping up before we have some time for questions or comments, I'm just going to paraphrase some pieces that came from our LANCET Oncology, our manifesto as it's called. So common sense oncology will promote interventions that measurably improve the lives of patients. We will celebrate well-conducted trials and promote effective treatments, but we will also be willing to speak up and challenge interventions that might cause more harm than good. With the equity piece, we will seek to decrease global and regional inequities in access to high-quality, affordable care. Improvements in the generation, interpretation, and communication of evidence will help close these gaps and move our field closer to a future in which a patient's outcome of cancer is not determined by where they live, what they can afford, or the strength of an industry marketing campaign. So just in closing, please encourage all of you to, you can read this material in our paper in Lancet and also our website, commonsenseoncology.org. Aaron and a few of our colleagues are very active on Twitter, as I'm sure you know, so please follow their writing as we seek to really grow this movement. This is, again, we're looking for people to become involved. On our website, you can register and become a member of the CSO movement. There's no charge. And over time, we're going to build new committees, working groups, project teams, and most importantly, disseminate information about how we can meaningfully exert change. So with that, I'll close. Thanks to Aaron for number one, being one of the catalysts to kickstart this entire initiative, and also for him and his family so graciously hosting the Booth family here in San Diego. Thanks very much.